What do we do? What I'd like to talk today is not about all the things we've learned over the past 100 years, but I'd like to talk about the future because there's hope. So I'm going to talk about precision, and this is giving the right medicine in the right dose to the right patient at the right amount of time and expecting an outstanding outcome. So I'll talk first about traditional medicine, then we'll talk about precision medicine and some challenges and solutions. First of all, the problem. This is chronic pancreatitis, and by now you all have seen a number of images. You know what it looks like. And what it is a syndrome, which means there are several signs and symptoms that occur together to define the disease. And it's around the issue of pancreatic inflammation, where there's scarring in some patients, but not everyone, maldigestion in some patients, diabetes mellitus in some patients, pain in some patients, and pancreatic cancer. The diagnosis is done by demonstrating irreversible damage to the pancreas, repeated CAT scans, MRI, ERCP, and endoscopic ultrasound until you demonstrate irreversible damage, and then we give symptomatic treatment. So what chronic pancreatitis really is a hopeless, irreversible condition that is expensive to diagnose and treat. Well, that's 2018 now. It's time to change. What have we learned in the traditional approach to these diseases, such as chronic pancreatitis? And so when I was your age, I looked in the New England Journal of Medicine and saw Medical Progress, Chronic Pancreatitis, a review of 100 years of research. And what they concluded was that chronic pancreatitis remains an enigmatic process of uncertain pathogenesis, unpredictable clinical course, and unclear treatment. The challenge is that the best practice is not good enough. Let's look at the definition of chronic pancreatitis, because this may be where the problem begins. Chronic pancreatitis was defined in 1984 as a continuing inflammatory process of the pancreas characterized by irreversible morphologic changes, typically, but not always, causing pain and/or permanent loss of function. So this was a diagnostic definition that was come up by a group of people from the British and Scottish Society in 1984 to help with the diagnosis using ERCP. The problem is that the inflammation develops, but in whom and why? And the irreversible changes take 5 years before they show up, in which time the patient's symptomatic and goes through all kinds of treatments. And the typical features are known, but they're highly variable. And why do some people have great changes and others don't? And Mel Wilcox published a very important paper from our North American Pancreatitis Study Group that showed that if you look at a CAT scan and measure how much fibrosis there's no correlation with pain. We see that the actual disease isn't actually defined, but rather the end-stage syndrome. The pain drives the intervention, which is mostly endoscopic and surgical, but we're not stopping the process. Early chronic pancreatitis cannot be diagnosed because, by definition, you have to have end-stage disease before you can make the diagnosis. The therapy is reactive and supportive, but it is not preventative. Little can be done to change the natural history, and many different genetic and environmental factors have been found to be associated with the disease, but they don't cause disease in most cases. So how did we get here? What is the foundation of medicine? Well, the 20th century medicine came out of the 19th century, historically, And this was the development of the germ theory of disease, because before that, disease treatment was just pragmatic, dogmatic, based on different therapy ideas, and all you had to have was a diploma that said doctor on it, and then you could do whatever the heck you wanted to. Then the germ theory came up, and this is the first time science was applied to medicine. And people like Louis Pasteur and Lister and others showed that you could have an infectious agent that caused a syndrome, a complex disease. And the whole point with the germ theory is that what was the one agent that caused a complex syndrome? You use the scientific method and Koch's postulates to show that a complex syndrome was caused by one factor, and then a clinical pathologic disease definition was there that said, in this disease, you have inflammation of an organ with a bug in it. And this is how medicine was built around these concepts of a single factor causing a complex disease. The result is that there's tremendous progress in infectious diseases, but there's very poor progress in complex diseases, and that's when there's two or more factors that are required. They can be gene-gene interactions or gene environment, but individual factors are not necessary or sufficient to cause the disease. So if you have one factor, it doesn't do it. If you have the other factor, it doesn't do it. It's only when they're in combination, and often it takes 3 or 4 factors in combination to cause the disease. So Koch's postulates cannot work, and you cannot make a diagnosis of the disease by definition. So you get very little guidance by following to the traditional approach to medicine. So this is another example. So if you have inflammation, pain, and organ dysfunction, you go, oh, you have an infection, it's a germ. Using Koch's postulates, you can zero in, find the bacteria causing these things, you kill the bacteria, inflammation, pain, and dysfunction goes away. Well, what happens if you do something and there is no germ? They say, oh, it's the germ, it's a gene that's causing this. But as we look inside of the person and start tracking the genetics, we find that, in fact, there's dozens of genes, and they're sort of associated, but not really, in not all patients, and some patients, and we don't know what to do with it. And you know what this teaches us? It teaches us that the germ theory has failed. A new paradigm is needed because it's not an infectious disease. It's a complex disease. You know what the new paradigm is? It's precision medicine. So what is the personalized medicine, and when is it needed? Well, it's needed when a syndrome is complex. That means there are multiple factors that all cause inflammation. The pathology looks the same, even though it's caused by a whole bunch of different things. Where if you look under the microscope and you see pathology, you don't know what's going to happen. There's all kinds of outcomes that can occur as well. When the treatment effects are unpredictable, and we have a statistic we use called number needed to treat. And most medicines take 4 to 5 patients to be treated with a medicine before one's expected to get better. We say, oh, isn't that great? And you go to a doctor and says, oh, we'll try this and then we'll try that, because we can't predict what's going to happen. It's needed for complex and functional diseases. So functional disorders where you have terrible pain in your intestine, but if you take a biopsy, the biopsy's normal. So they say, oh, functional, it's probably in your head. Well, there could be real disease there. It just doesn't have pathology. So it's associated with focusing on the mechanism instead of associations, and it takes modeling and simulation. So it's trying to figure out what is actually going wrong at a molecular level. The advantage is that if you can figure out what the actual problem is and treat it in an individual person, they'll get better. So it's not relying on the average of the population, it's on a person-by-person basis. And this requires a new framework, because you can't use the old paradigm, and these are model-based things, and, but they're effective for one person. But it turns out the pancreas is the perfect organ to do this in because it is relatively simple. There's only 3 cell types. They each do one thing. We know how it works, and the complications of the environment are minimized because it's protected from trauma, protected from direct contact with the environment, and we can now solve the problem in the pancreas. So precision medicine can actually occur in patients with pancreatic disease now. Now we know genetics is important, and there are several genes that are being used. The first one that was discovered was hereditary pancreatitis, and there's the hereditary pancreatitis gene in purple on top and the SPINK gene below. It causes acute pancreatitis in 80% of the people that have the mutation, and chronic pancreatitis in 50%, and pancreatic cancer occurs in about 15% with the chronic pancreatitis. And this shows the natural history in a population. So of all the people that have the worst known mutation, by age 10, half of them have the disease and the other half don't. By age 20, half of them have lost their pancreas and the other half haven't. By age 50, some of them are starting to develop pancreatic cancer. Others have diabetes, others have chronic pancreatitis, others have never even had a symptom. It's the same mutation. And this tells us it's a complex milieu that the pieces are in. Another important one is the cystic fibrosis gene, CFTR. And this shows how much cystic fibrosis gene is expressed in each of the different organs. So all the organs are lined up. And guess which organ has the most CFTR in it of anyone? It's the pancreas. People think of the lung because that's the one that was life-threatening after we learned how to treat the pancreas. So the phenotype of cystic fibrosis is a baby that eats but loses weight. It's held by the nursemaid. The nursemaid kisses it, tastes salt, and says that baby will die. And no matter how much they fed the baby, it would die. Then the doctors would take the baby into the back room and cut it open and check the organs, and there was only one organ that was messed up, and it had cyst and fibrosis because it was chronic pancreatitis in a baby, a newborn. And so they called the disease cystic fibrosis because there was cyst and fibrosis in the pancreas. And finally somebody said, you know, why don't we take the pancreas from cows and feed it to the babies and see if it lives? And they did, and it didn't work. So they took pancreas from pigs and fed it to the babies, and they lived. Because pig pancreas dissolves proteins, and cows are herbivores, and it doesn't work for proteins. And so now, the best treatment we have for pancreatic disease is to take pancreatic enzymes from pigs, put them in capsules, and eat them with every meal. And those are, it's called PERT, okay? And so if you do that, the baby will live. And that started, last century. But then once they can digest their food, then the infections of the lungs start taking over, and that's how we see cystic fibrosis as the lung disease. But it's actually mostly the pancreas. Now what's interesting is there's about 2,000 variants that have been identified, but it turns out the most common is Delta F508, but each of these variants actually can be classified by what it does to mess up the gene. And some of them, you have no protein at all. Others, they don't go to the right place. Others, they go to the surface, but they don't work. Others, they work okay, but not as good as they should. Sometimes there's not enough protein. Sometimes it's unstable. So all of these can be mapped out. Why is that important? Because it turns out that we can target the therapy based on what the problem is. And now, if you look at the amount or the function, there are medications that you can give that can fix this. It's one of the most amazing things. So drugs like ivacaftor or lumacaftor, if you give this, you can correct these genetic problems so that even though the genetic variant is still there, these molecules begin working again, and people that were dying of cystic fibrosis suddenly come back to life. They start breathing, sleeping, eating, growing. Amazing. These are major pancreatitis genes, and there was just a paper that came out that showed that people with recurrent acute pancreatitis that were treated with these medications, the pancreatitis stopped and they started getting better. But you have to know that they have a CFTR mutation. You have to figure out what the underlying problem is, because the pancreatitis looks like every other kind of pancreatitis, but depending on what the mutation is, there are specific treatments, and that is personalized medicine. So here's a study that looked to see patients with idiopathic pancreatitis. There's 22 patients from France, and what you see is they have a whole series of mutations. So I'm working with a group now. We're looking at 12 mutations, and it turns out that patients often have 4, 5, or 6 different mutations and combinations of mutations that cause disease, and we need to be able to sort these out. Something else we did was very interesting, is we looked at a bunch of patients that had pancreatitis but no lung disease, and we looked to see what kind of mutations they are, and what we found is that there were some that we called bicarbonate deficit because they messed up bicarbonate secretion and not chloride secretion, and it turns out that they're highly associated with pancreatic disease, but they're benign. Oh, I'm sorry, they're benign when they were phenotyped by pulmonary doctors because they don't see patients with pancreatitis without lung disease. And so there are 9 mutations that actually cause pancreatitis because the pancreas uses CFTR to secrete bicarbonate, and the lung uses it to secrete chloride. And so even within these mutations, you have to know what the problem is in order to get the right disease and treat it correctly. So the bicarbonate defective mutations affect the pancreas, but it turns out there's other organs that also use CFTR to secrete bicarbonate. One is the male reproductive system, and the other are the sinuses, because the mucus that your sinuses make is really thick and tenacious. It's like rubber cement. But if you secrete bicarbonate, it unravels and it puffs up and becomes really soft and fluffy. So when you blow your nose, you get this relaxing, smooth discharge, and rather than everything being socked in. And so it turns out that we went back and looked at the patients with pancreatitis and said, if these have mutations, do you have male reproduction problems if you're a man, or sinusitis? And it turns out the risk of having sinusitis is up about 3 to 4 times higher than expected if you have these mutations. And do you know what the odds ratio is of having male infertility if you have these pancreatitis and you're a man? It's not 1.5, it's not 2, it's not 3, it's not 5, or the high number of 10. It's 300 times the normal risk. That's precision medicine. So now we have the problem in that here's a partial list of some of the genes that are known to be important, modifier genes, biomarkers, experimental markers, and this is only a partial list. Now the doctors taking care of a patient have some time to look at this and to put all the, not just the list of problems, the list of results together. They have to do this in 1 minute and make a decision. This is the future, is to figure out how to do this. So do the doctors have to get a PhD in genetics to be able to actually read a report? Well, we don't think so. We have to put together models to help us think about this. And the first thing we see is that chronic pancreatitis actually comes from patients who have acute pancreatitis. About 1/3 of those get recurrent acute, and a third of those get chronic pancreatitis. So actually, acute pancreatitis warns us that you're on a track and that some patients are going to progress and others won't. Secondly, what percentage of patients of chronic pancreatitis come through this pathway? It turns out that some patients can get pancreatitis, chronic pancreatitis, without recurrent acute pancreatitis, but this is a major driver. And so now we can start seeing warning signs in the clinic that somebody's going the wrong direction and they're going there fast, and now's the time to intervene before you have an irreversible disease, right? Because if it's irreversible, it's too late. Now we have a warning that we're on the wrong track, and those are the patients we want to target. And now we're starting to be able to learn how to target it. And so what we've done is we've come up with a mechanistic definition that says if you have risk factors and clinical symptoms, you're in trouble, and here's what's going to happen over time. But we don't want to wait until you have these features here, which can each develop independently. We want to be able to organize all this information. What we need is to be able to diagnose a person not at the end of the disease, but right when they have the acute and recurrent acute pancreatitis, and we should be starting the treatment earlier on in order to prevent the development of a disease that we cannot cure. And so this end-stage disease should be relegated to the history book, just like it is with diseases like polio, which everybody used to be terrified of polio. Who's the last person you've seen that has polio, and what do they look like? You have to go to a history book, and this is what we should do with chronic pancreatitis. So the good news is we already have a bunch of therapies. These are based on genetic and other mechanisms. There's therapy for CFTR. There's ones coming down the pipeline for PRSS1. Hyperlipidemia, major driver. We can identify that and treat it. There's unfolded protein disorders, oxidative stress, genes associated with alcohol and smoking that massively accelerate the problem, obstruction. The future is not in just identifying the genetics. It's in putting it together and offering the right treatment to the right patient at the right time. And this is at our fingertips. So what is the future? Well, in summary, the germ theory of disease that all physicians are trained in by law is an inadequate framework for complex disorders such as chronic pancreatitis. True personalized medicine requires complex disease modeling. We have to be able to think about this. The problem is that nobody can calculate all of these variables in their mind, especially if they only have a few minutes. So new tools are needed. So what is needed for precision medicine? Can you remember a few years ago when Obama initiated the Precision Medicine Initiative? Well, for those next steps, there was a very nice editorial, a healthcare policy that was put out by a guy named Isaac Cohen from Harvard. And he said, you know what, there's a bunch of barriers. There's at least 10 of them that need to be achieved in order to provide personalized medicine. You have to be able to get to the patient's health records. You've got to have accurate and reproducible data. The clinical and research data sets have to be harmonized. You have to have patients that buy into this. You have to be able to measure it over time. You have to be able to automatically update all the information. You have to have real-time decision support at the point of care so the doctor knows what to do right now. It's got to be affordable. It's got to represent all the different ethnic and ancestral backgrounds. And you've got to educate the health workers. Good luck. But in many instances, the patients will become the precision medicine experts. You know why? It's their life. It is their life. It's not a 5-minute job. It is everything to them, and they will spend the time to figure out how to do this. Now, about 10 years ago, there was a very important development that came that's revolutionized the future. It's something that allows all these things to occur simultaneously between the physician and the patient without having to go to the hospital every time and all these things. Real time, connecting all the pieces together. You know what the invention was? It was a smartphone. Wouldn't it be amazing if we could integrate all this information together and have it on a smartphone so the patient and the physician can be connected, and all of the massive amount of information that's necessary to solve the problem can be done in the cloud so that the patient knows exactly what to do, and anytime there's a problem, the physician can be alerted, but they get the right medicine at the right dose at the right time to prevent the development of disease that nobody can cure. That's the precision medicine, and that is what we're working to deliver today. Thank you.